Good evening, everyone. Welcome back to my IVF and the European Fertility Society. We are back once again. Today is Wednesday. As you know, we were here before. So if you had a chance to watch our webinar yesterday, we are back. But this time we are going to talk about completely different topic. Yesterday it was PRP, but today we will discuss miscarriages and we will talk about PGT-A and the role in miscarriages as well. And we have the person to definitely explain it all, Dr. Francisco Anaya from Alicante or Vista Hermosa Clinic. So welcome back. As we already discussed before the event, it's been over a year. We had a last chance to see you here. So I'm really happy to have you here. How are you?
I'm fine, thanks. I'm also very happy to be here with you again. And well, just in a few moments, I will try to explain a bit the PGT-A, and I'm very happy to be with all you here.
Thank you so much indeed for joining us today. Just before we start, as always, let me remind that my IVF the European Fertility Society, has been created simply because we want to support patients who are struggling with infertility or trying to conceive. And as you know, we have touched many aspects of IVF, but also topics from genetics to supplements to new methods, so everything that simply can help you out. And of course, we invite all the best experts in the field to simply answer your questions. And today is no different. We will talk about miscarriages, PGT-A. Dr. Francisco will start with his presentation to explain all the aspects of this. But afterwards, I know you will have lots of questions. So please remember to put those in the chat. And Dr. Anaya will simply answer them for you right after his presentation. And I can only add that it's all anonymous, so don't hesitate. We are here simply to help you out with anything that's on your mind, and whether you are looking for some advice or simply a second opinion, whatever it is, we are definitely happy to help you out. And I think we can go ahead with the presentation. And remember, you can type the questions in the chat during the presentation or afterwards, and we will take care of those right after it. So let's get going with this. Okay, Dr. Naya?
Okay, perfect. So
thank you so much.
Thank you. Good afternoon again, and thanks for inviting me to one of these interesting discussions of the European Fertility Society. Well, as Caroline mentioned before, I am Francisco Anaya, gynecologist at UR Vista Hermosa, and today I will try to explain and clarify how important is PGT-A and how can this technique help us to avoid or at least decrease as much as possible the risk of miscarriage for our patients. First of all, I would like to show you the classical pyramid of pregnancies, where we can see how bad is human being at reproduction. So from all our conceptions, we can see here how 60% will be lost previous to implantation. So previous to be clinical, we won't be aware of those. And from the rest 40%, just a 30% will end with a live birth. So we will still have a 10 to 15% more miscarriages that will be the clinical ones. So these are the ones that we are being aware of. From this pyramid, we learn how important is miscarriage or how frequent is miscarriage in our pregnancy. And IVF can, through PGT-A, help us to decrease these rates. We will see. I would like to explain a bit all the possible causes of miscarriage, and afterwards we will talk more deeply about PGT-A. But before, I would like to have a look at all the possible causes, okay? So when we try to classify miscarriages, we normally use this classification we call a biochemical loss, a miscarriage that happens after a positive test, but before we have a scan or a histological verification, normally before 6 weeks of pregnancy. And a clinical miscarriage, we call it when we have had a scan or sonographic or histological verification of an intrauterine gestation. And we can still divide them in early clinical loss before 12 weeks of pregnancy, and late clinical loss after 12 weeks. Just a few numbers or data about miscarriages. We already know, we said it before, that around 15% of the pregnancies will deliver in a first trimester miscarriage. The percentage will increase with the woman's age. We know that the sporadic miscarriage is the most common complication of early pregnancy. And this can be due to many reasons that we will see now, but genetic disorders of the embryo is the most common cause of miscarriage. 85% of the miscarriages are secondary to genetic disorders of the embryo. And this is where the PGT-A is very important to avoid this. The other 15% could be multifactorial, including thrombophilic issues, immunologic disorders, uterine anomalies, endometrial problems, metabolic disorders, infections, and some other. I will try to go through this and explain a bit which are the more common, and I'm sure you will have most of you will know about them. So after you can ask about them also if you want. When we talk about thrombophilic causes of miscarriage, we have to think about the antiphospholipid syndrome, other genetic causes like factor 5 of Leiden, some mutations, and also factor 2, factor 12. Also antithrombin, and protein Z and protein S are also important for the miscarriages. And most of these cases, the treatment is with low-dose aspirin, heparin, or special folate supplementation. But when we have a miscarriage or maybe a repeated miscarriage, we also study these thrombophilic causes. When we talk about immunologic factors affecting the pregnancy, well, we know the KIR-HLA, it's a immunologic condition that could affect sometimes the development of the pregnancy. Also, the famous NK cells also can affect pregnancy and cause a miscarriage, and some other immunologic systemic diseases. Uterine factors affecting pregnancy, of course, we have many. Of course, polyps, fibroids, maybe remains of previous abortions, maybe adherences in the uterus, septums, or uterine anomalies such as T-shaped uterus or biconioate. And many of these pathologies can be treated previous to our transfer. So we must remove our polyps by hysteroscopy, sometimes remove the fibroids if we think that they are affecting the endometrial cavity. Of course, remove adherences, septums, and any other pathology. Okay. About fibroids, I would like to explain, even that is not the main reason of today's discussion, but I think it's important to explain that we have a new technique for treating fibroids that we are carrying out in our clinic for the last 3 years, and that let us treat some fibroids that were previously very difficult to remove surgically. It is called radiofrequency, and it is a non-invasive way of treating these fibroids with a very simple procedure, and it results in a decrease of size of around an 80%, and some of them even disappear. So it's really impressive, the results we have with this. And as you see here, there are different kinds of fibroids, and this technique let us treat the types 1, 0, 2, 3, and even 4, not the more external ones, but the ones that are very near the endometrial cavity. So it's very interesting. And well, after having enumerated all these factors, well, there are some more, like endometrial disorders, metabolic disorders, infections, endometritis, or sometimes non-adequate endometrial growing due to infections or previous surgeries or many other reasons. We will talk about PGT-A, and I will try to explain how important it is. And I think after this 8 or 10 slides, you will be able to understand it perfectly. Well, we know that we can carry out genetic studies to the embryo, and they can give us the security of transferring healthy euploid embryos. There are three kinds of different genetic studies, which are PGT-A, PGT-M, and PGT-SR. Well, the one is important for the miscarriage is the PGT-A, is the one we are going to talk today, because the PGT-M is looking for a special kind of illness, inherited illness, and is not related to miscarriage. Okay, so what is a PGT-A? It's a biopsy we carry out to the trophectoderm, that it's the outer part of the cell of the blastocyst, that let us know if the embryo is euploid, that means normal chromosomic dotation, or not. We are able to discard with this technique the non-euploid embryos, and this let us increase our success rates and decrease the rates of miscarriage. About the technique, we carry out the IVF or the ICSI. We let our embryos develop for 5 days of culture. And when the embryo arrives to blastocyst stage, then we perform the biopsy to the trophectoderm. As I said before, it's the outer part of the cell, as you can see here. And we take a very little part of the embryo, and we analyze genetically. Normally, the embryos are frozen after the biopsy, though we can, in some cases, perform it fresh and transfer the embryo the next day of the biopsy. The four kind of results we can have from this biopsy is this four I show you here. We can have a healthy embryo, which is the one with the green tick, of course, perfect embryo for transfer. The second one, the red one, is the aneuploid embryo, the non-healthy embryo, and we won't be able to transfer this one. And we have two more options that I think it's important to explain, which is the third one is a mosaicism. It's a special situation where the embryo has two different kinds of cells inside of him. So we have to individualize what we do with these embryos. We classify them in low-grade mosaicism and high-grade mosaicism, depending on the percentage of the abnormal cells it has. And we discuss individually with our genetic team and with our patients. But nowadays, the low-grade mosaicism can be transferred with the same security as a healthy embryo. So we consider healthy embryos that have been contaminated with placental cells. And the fourth embryo is the non-informative. Sometimes it happens rarely today, but sometimes we don't have any information. The cells doesn't grow in the culture, so we don't have any information about that embryo. It's a strange situation, but sometimes it happens. Well, about results, well, we know already that rates of aneuploidy are related to woman's age. For example, with a 40-year-old woman, around 70% of the embryos analyzed will be aneuploid. So we will need normally a good number of embryos to be able to have just one to transfer, euploid one to transfer. And also in couples with repeated miscarriages, the percentage of aneuploidy rates are higher than expected. And this is the reason of the repeated miscarriages in most of the cases. So to these couples, we should explain that our expected rate of aneuploid embryos is going to be high. Indications of PGT, well, I find many, but of course we should offer to all our patients over 38-year-old, and should be almost compulsory for over 40s. Also in cases of repeated miscarriages, as we said before, implantation failure, of course, when we have an abnormal FISH test. A FISH test is a chromosomical test of the sperm, and if it's abnormal, we also recommend PGT. And maybe in the future will be done to everybody, always, but maybe that's the future. Another technique we have nowadays since 2 years ago, and it's very, very, very impressive, is that we are able to analyze chromosomically the embryo, avoiding the biopsy. It's what we call the non-invasive PGT. And we study the culture media where the embryo has developed during the 5 days of culture. And we have a 85% of correlationship with the PGT-A. So it's not an exact diagnosis. It doesn't let us discard any embryo, just give us information to select the best embryo for the transfer, not just morphologically as we do with the time-lapse systems, but also genetically. It's going to give us a result saying, for example, this embryo has more than 85% possibilities of being euploid, or this other embryo has less than 30% of possibilities of being euploid. So we can choose which embryo is better to transfer first. And of course, if we have any doubts about the embryos, we can always carry out the biopsy in a second step. I think this is a very important technique, and maybe we are now recommending for many of our patients, and I think it has a very big strength for low-risk patients where maybe we don't need the exact diagnosis, but we have to classify the embryos in order to shorten our time to pregnancy. About the technique of doing the non-invasive PGT is the same. It's very, very similar. We carry out the ICSI, we do the embryo culture, and before freezing the embryo on day 5 or 6, we take the culture media and we study it genetically. In this case, the embryo has to be frozen in all the cases. And when we have the results 2 or 3 weeks later, we will know genetically how the embryo is, and we will be able to choose the best one for our transfer. And now for ending my chat, I will just show you some graphs that I think are impressive in terms of efficacy and accuracy of the PGT-A. In the first one, it's related the implantation rate with maternal age, and you can see how it decreases with age. We can see the red lines showing the non-genetically screened embryos, how we have almost a 40% in young patients of implantation, 30% in 35-year-old women, and it decreases until 10% in 41-year-old women. So the decrease is very important, and we can see how genetically tested embryos remains very high at implantation rates and are almost the same for all ages. So we can think that, of course, we think that the difficulty in the older patients for getting pregnant is because of the rate of aneuploidies. So we shouldn't transfer any embryo to these patients without a genetic test, because we see that probably we won't get a pregnancy, and afterwards we will see that the rate of miscarriage also is too high to do it. The second one is similar. Tell us about it's more actual, more recent, and it also relates the pregnancy rate per transfer, and we can see how in genetic tested embryos it remains very high for all patients, but we see how it decreases with age in non-genetically tested embryos. So for our older patients, maybe over 38-year-old should be carried out for all the embryos. Here we see the rates of aneuploidy expected per age group. And we see how in young patients we have 27% of aneuploidy, so it's not very low, not so low. But we can see how over 40-year-old we are over 70% of aneuploid embryos in these patients. So it is very important, I say it again, not to transfer any embryo without genetic test, because we have many chances of an implantation failure or a miscarriage, which is or a abnormal chromosomically baby, which is still worse. Okay. And just 2 last graphs to show you the miscarriage rate, which is the main topic of our chat today. We can see how in under 35-year-old women, the rate of miscarriage is the same if we perform PGT or not. But as we are getting older, the rate of miscarriage in non-tested embryos is very high, and it arrives to 55% in patients over 42-year-old. Even transferring blastocyst, the rate of miscarriage is so high. So it's very important to carry out the PGT to keep the miscarriage rate as low as possible in these patients. And the last one just shows us the relation of a live birth rate with PGT tested embryos. And we see how, again, it decreases in untested embryos and remains quite high for all the age groups, in PGT tested embryos. So just I think that it's quite clear the importance of the PGT in avoiding risks of miscarriage and implantation failure. And just as conclusions, I would like to say that genetic disorders of the embryo are the main cause of miscarriages, up to 85%. That PGT-A let us select the euploid embryos, increasing our success rates and decreasing the risk of miscarriage even in older patients. Also, PGT-A let us shorten time to pregnancy and avoid many undesired events. And that non-invasive PGT is a valid way to select the best embryo for our transfer and can be done in any couple. So our gold standard in reproduction should be to individualize our treatment depending on the couple on the patient we have in front of us, to achieve the desired pregnancy as soon as possible, minimizing risks. And I think that PGT is very important for this goal. So, well, now I'm ready to try to answer all your questions.
Excellent. Thank you so much indeed for walking us through the steps and how PGT-A works. Now it will be time for your questions. There are some questions left already, so we will take care of those right away. Just let me remind you, everyone, that we will take around 30 minutes for the questions. So fire away. We are here for you. And Dr. Anaya, here's the first question that we have. Let me just show you. Okay, so PCOS patient, 38, only MTHFR heterozygote found from all these tests, fraxiparin and folic acid included, got 11 blastocysts at 36, 7 transferred in 4 embryo transfers, but every time miscarriage, around 6 weeks gestation. What could be the reason? Anything you can advise here?
Well, it's quite an impressive case, because every time miscarriage around 6 weeks. Of course, I think this is perfect for our subject today. We should carry out PGT-A to these embryos, because in that way, first of all, we would have more information about the embryos. We would know now if we were transferring healthy embryos, or maybe we never had any possibility of success because they were aneuploid embryos. So the first thing I can recommend this patient is to do a PGT-A to the embryos in their next cycle. And of course, also they should have a good assessment about the uterus, endometrium shape and endometrial cavity, because when we have the miscarriage is so frequent, we have to be sure that the rest, the 85% is covered by the PGT-A, but we have to cover also the 15 rest.
All right. Thank you so much indeed for this. And actually, Dana has another question here. So let me just show you straight away, and we will go back to the previous one. So do you charge for PGT-A per embryo or group of embryos? I have 4 embryos left.
Well, normally we charge per embryo, I think. But if there are many embryos, we have a special, there's a maximum. I think we have a special price for a big number of embryos, but I'm not sure about this. They should better contact the clinic about this. Okay.
Of course. When it comes to the cost, I know that it's better to ask the coordinators. They will be definitely able to provide all the prices, etc. So you can always reach out, or you can send in an email to me. I will write it in a minute in the chat, and we will be happy to forward this, and then the team will be definitely able to help you out. I just want to remind everyone that if you have any questions, type those in the chat, okay? And now we will go for the question from Lisa, and let me just show you as well. So how can I decide if PGT is right for me after experiencing a miscarriage? How is it done at your clinic? I'm 38. PGT is not available where I live.
Yeah, you are 38, so in my opinion, PGT-A is for you. Still more when you have had a miscarriage already. So we know that this is the main cause. And of course, we would recommend you PGT-A. We do it in our clinic. Of course, you would have to come here to do the egg collection or bring here the embryos. It's better to come to our clinic to do the egg collection, because in that way we can do the embryo culture and we can do the biopsy in fresh embryos. So I think it has some advantages. And after that, normally we freeze them and we wait until the results, and then we can organize the embryo transfer for a month later or so. So I think it's quite easy technique. We do it with many international patients, and I would really recommend that, because in that way we would know if we have a real euploid embryo. We have almost a 65% or 70% of rates of success. And if we don't have any euploid embryo, which I hope is not your case, at least we are not going into a implantation failure, a miscarriage, and a long of time losing our money and our time. So we go straight ahead to what we have to do.
Yeah, that makes it clear, of course. That way it's so you can avoid transfers which will end up in miscarriage, for example, as well, that way, right?
Yeah,
so,
of course.
Thank you so much for that. And as you can see, more questions are coming in. I just need to go here. So is it true that PCOS patients have higher chances of miscarriage?
Yeah, it's a difficult question. Okay, with PCOS patients, we have advantages in IVF because we are getting a huge number of eggs. So normally, even that the quality egg is always under study, and it is said, and we believe that maybe the egg quality is not the best one, but well, we from the other part, we have a very high number of eggs, which can compensate that way. We will have a good number of embryos normally, and they can be PGT-A tested, of course. So it's a good, the risk of miscarriage can be decreased in that way. But yes, it's very important for PCOS patients to consider the rest of the PCOS syndrome. So to have to control the weight, control thyroid, control diabetes, control hypertension, control all the other facts that could affect also the pregnancy.
Yeah. All right. Hope that helps. And of course, if you have any follow-ups, you know what to do. Yeah, there's a thank you from Dana for you as well. And let me just go to the next question. Just give me a second. I also need to mark this as a question and just cannot do it now. Okay, it's working now. Sorry. Here it is. So what can you say about small gestational sac? The embryo was PGT-A euploid, but heartbeat was stopped because of this sac syndrome. Gestational sac syndrome. The embryo, was euploid, sorry, but gestational sac did not increase in size. Anything you can advise here?
Yeah, unfortunately, this happens. So as we said before, PGT-A decreases the rate of miscarriage and covers 85% of the causes, but there's still 10% or 15% of miscarriages that we don't really know why happen. So sometimes we study all these factors. We study the uterus, endometrium, immunological disorders, thrombophilic disorders, all, and we don't get any reason, and miscarriages still happen. So we have to cover all we are able to and decrease the rate of miscarriage as much as we can, but it's never going to disappear. Sometimes happens. Maybe could be, sometimes we think it's due to special difficulties in the vascularization of the uterus, sometimes due to many other factors of the body or any other thing that we still don't know, but still happens.
Okay.
But I would like to tell this patient that if she is able to create euploid embryos, finally she will get it. So the main difficulty for many patients is that when we try to study the embryos, sometimes we find that we don't get any euploid, or we get very low rate embryos. So.
So as long as you have euploid embryos, there is always a chance, right?
So,
This is what matters. Okay. All right. Thank you so much indeed for that. For encouragement as well, for surely. All right. Let's have a look. Belinda has another question here. From reading many articles, it says PGT-A does not guarantee live birth, right? Also, would you be discarding mosaic embryos because there is a chance they can self-correct? So not giving it a chance seems not right. What do you think?
Yeah, I totally agree. Well, of course, PGT-A does not guarantee a live birth. I wish it would, but still, as we said before, there are many other reasons for a miscarriage and many other maternal conditions that could affect pregnancy even later. So it's difficult to guarantee this. But it guarantees that the embryo is chromosomically healthy, and this avoids many of the risks. So it's very important. And for the second question, yes, of course, as I said before, mosaic cells, we discuss them individually with the genetic team, depending on the alteration of the embryo, depending on how percentage the anomaly line is present, and also depending which kind of anomaly it has. So, for example, even if it's a low-grade mosaicism, but the affection is compatible with life, like a Down syndrome, Turner syndrome, normally we recommend not to transfer. But if it's a low-grade mosaicism and the anomaly line is a strange one, only related to miscarriage or early miscarriages, then we normally transfer them if the patient accepts, and we are getting good results with them. They don't arrive to the 65%, but we are not so far. Maybe I think we are between 40 and 50% of rate of pregnancies with low risk mosaicism. So of course they can be transferred.
Okay. Thank you so much again. That's definitely interesting. Mosaicism definitely is an interesting topic here. Thank you for bringing this question as well. Next question also interesting. So can PGT-A test give false positives to an egg donor of a young, healthy donor, right?
Well, I think in medicine, nothing is 100% sure. Nothing is black or white. So, of course, we could have false positives if they are described in the technique, but the rate of false positives is very low. There are some studies that some years ago, some people transferred non-euploid embryos, and some little number of them developed a healthy baby finally. So it's described and it exists, but well, we don't know exactly the number of it, and I think the risk for a false positive is very low, and normally we always discard the aneuploid embryos.
Okay. Next question on adenomyosis. So do patients with adenomyosis present a higher chance of a biochemical or miscarriage?
Yeah, it's very interesting. I didn't speak about adenomyosis today because it was not the subject of the chat, but it's very important. It's a pathology that we are diagnosing more and more nowadays, and of course in endometriosis patients and older patients, the uterus is getting more fibrotic and more adenomyotic with time. Now we are treating adenomyosis with quite good results because it has not a very good treatment, but we used some hormonal therapies years ago, and now we are treating with the radiofrequency I mentioned before with very good results. But of course, adenomyosis also is conditioning our miscarriage rate and is increasing the miscarriage rate and also the implantation failure. So yeah, it's a very important issue.
Okay, thank you again. And let me just go for our next question, a bit of a longer one. I'm 39 and a half, had one embryo transfer in May without success. I have Douglas endometriosis and Hashimoto syndrome. AMH was 2.50 nanograms. And in December, in 14 days, I will start next stimulation for ICSI with PGT-A. I have a cold since 1 week. Should I wait with the stimulation to the next cycle? What else may be helpful for success? Anything you can advise?
For the cold, I think if if you are not very affected, it's not necessary to wait. You can start because the stimulation is going to last for 15 days, and you will be perfect in 2 or 3 days, I suppose. And well, I think your AMH is very good. So I hope you have a good number of embryos. I didn't see anything about the sperm.
Yeah.
I think it's very important to assess you properly to know you, because we have talked a lot about the woman's age and the PGT-A about this, but it's very important to assess about the sperm in terms of result of the IVF, because it's the other 50%. And the sperm is going to condition our embryo development and also our rate of aneuploid embryos, of course. But I think your way is the right way. You are going to do an IVF because you have a good ovarian reserve, and you're going to do PGT-A to the embryos, trying to see if you have any euploid and to avoid risks. I think it's perfect.
Mm-hmm. Okay, brilliant. Thank you so much. Next question from Helen, another interesting one. Let's have a look. Okay, so considering your extensive research on the use of PRP in enhancing endometrial receptivity ovarian stimulation, how do you see the integration of PRP with PGT-A influencing the overall success rate of IVF treatments, particularly in patients with a history of recurrent miscarriages?
It's again a very interesting question, and we are now trying to see if we find any link between PRP and our results with genetic tests to the embryos. We still don't have any result about it, but unfortunately, in my opinion, it's a personal opinion, I think that PRP is going to increase sometimes, but definitely is going to increase our ovarian response. I think we find very useful in young patients with low ovarian reserve, but it's not affecting, we think that it's not affecting the quality of the egg, just the number of the eggs. So at this time, we cannot say that PRP is going to increase the number of euploid embryos, the rate of euploid embryos. I don't think so. Okay. Hopefully in the future we can say another thing. And about the PRP in endometrium, we are very interested in this because we are having very good results. But it's just about implantation of embryos. We need the euploid and healthy embryo to implant, and afterwards we have to prepare correctly the endometrium and do the PRP for receptivity. But it's not going to work if the embryo is not euploid, of course.
Okay. Definitely interesting subject here. We could talk a lot about it, even though there's no current studies that show this, prove it, right? So thank you so much, Helen, for bringing this up as well. So, all right, thank you. And Helen has one more question. I will show it to you. So given it, so this is here. So are there any current emerging therapies aimed at modulating inhibins and activins to enhance endometrial receptivity and improve IVF success rates? How might these therapies intersect with the use of PGT-A in patients with a history of recurrent miscarriages?
I can see that Helen has deeply studied
Definitely
Yeah. About endometrial receptivity, and yes, there are many therapies that are trying to be developed to modulate the inhibins and activins, and that's one of the reasons of the PRP. So, well, I think PRP is the best of all these therapies. We started trying with another treatments in endometrium, in blood, in endometrium, in many different treatments during the last 10 or 15 years. But definitely PRP is the one that has the best results. So we think the way that PRP affects endometrium is exactly modulating its response. And this is being studied, but we still don't have the exact root why it acts.
Of course, still need to wait for some more data on that as well, right?
But the rate of implantation, embryo implantation, when we talk about grade A embryos or PGT-A tested embryos in patients with endometrial PRP previous to transfer, is very good. So we find that we are using it in implantation failures, and we are using it also in non-good endometrial developments, and we are getting impressive results with this. So we are very interested in this.
Sounds good. Definitely promising as well, right?
Yeah.
Good. Thank you so much for that. Possibly our final question. So if you have more, this will be the final call. So go ahead, type those in. The question again has a few details here, as you can see: 42, AMH 1.04 nanograms, FSH 9.9, AFC 11 with repeated implantation failures. After stimulation, we are usually able to get around 4-5 embryos. We are being advised to do a double stimulation so we can collect more eggs and embryos. How many stimulations would you recommend for our case and in our specific situation? How many minimum embryos will we need to hopefully get at least one euploid embryo? Anything you can
Okay, yeah, it's
answer?
a very interesting question. Also, in this case, we have a 40-year-old, Karine is a 40-year-old woman with a quite good anti-Mullerian hormone for her age, good follicle counting, and very good embryo development. So if she's able to develop 4 or 5 blastocysts, it's a very good number. But I can see nothing about how many euploid embryos. So from the exposition I mentioned before, when you are 42-year-old, just for the age, we expect around 85%, 80 to 85% of aneuploid embryos. So if we look at statistics purely, we need around 9 or 10 embryos to get one euploid embryo. But of course, this is very difficult to assess because we are in statistics. The good embryo would be the first, or the 10th, or the 25th one. So we don't know how many embryos exactly. Normally 10, but it's very important to study them genetically, because when you are 42, sometimes all the embryos are affected by chromosomic abnormalities. And we find that the IVF rate of success rate for these patients is under 5%, even in good with good anti-Mullerian hormones. So I would do a last cycle. I would study genetically the embryos. If I have one, then I find it is worth. If we have one euploid, I find it's worth to transfer it and to try it again, because she's able to generate euploid embryos. But if we analyze 4 or 5 or 6 embryos and we don't find any euploid, maybe we should consider donation.
Brilliant again. Thank you so much. As I mentioned, I think that was our final question. I do believe it was really helpful session for you, and the presentation, of course, as well. Thank you everyone for joining. Dr. Anaya, as you can see, there is a comment from Helen as well. Your work not only enhances our understanding, but also brings hope to many patients. Couldn't agree more. So thank you so much indeed for your expertise, for your time, and of course for providing all those answers and giving a bit of hope, I think, as
No, it's a
well.
pleasure to be here again, and I'm really interested in all the questions, and I'm very happy to be here. I like it.
Glad to hear it, and we are looking forward to have you here once again. So thank you a lot for today. Let me just remind that Dr. Anaya Blanes, he is from Vista Hermosa Clinic in Alicante. Thank you, everyone, for joining, for your questions, for your active participation. I also want to add that we will be back actually tomorrow. We will talk about egg donation, and we will talk about epigenetics, which is also an interesting topic. So if you have any questions on this, join us tomorrow at 7 p.m. London time. Dr. Anaya, thank you so much. Have a lovely evening, everyone. And of course, we will be back here. And I'm looking forward to some more events with you as well. Thank you.
Thank you very much,
Take care.
Caroline. See you soon. Bye.
Thank you. Bye.
Bye.